About the Varicella-Zoster virus. It's a virus that we don't talk about as much, but there have been some important recent developments. And so since I didn't know as much about it as some of the other viruses that we more commonly run into, I took the opportunity to learn something about it. Okay, we'll start with a puzzling case. This was a man who was born in 1923. He was a Navy lieutenant in World War II. After World War II, he attended the Harvard Law School and had a prominent career as a lawyer. He had a case of zoster involving a shoulder and arm in 2007 at age 84. Until then, he was neurologically completely intact, as far as we know. Then within months of that, he started to have difficulty with balance and gait. Mild confusion started in 2010 at age 87. No definite diagnosis was ever reached. His internist suggested this was a possible variant of Parkinson's, but he didn't have any resting tremor. Problems with gait, balance, and confusion progressed. By 2011, at age 88, he needed 24-hour caregivers. Died in 2015 at age 92, unable to walk at all and moderately confused. Did zoster have anything to do with his neurologic problems, or were they just age-related or something else? Okay, the Varicella-Zoster virus, it's a DNA virus. It's one of the herpes family. It's caught by the respiratory route and infects lymphoid tissue in the throat. Then it spreads around the body in the bloodstream and infects the skin. And that's when we get the characteristic chickenpox rash. Here's a chickenpox, the generalized rash, especially as you'll see it's much more on the trunk than on the arms. And this is very characteristic of chickenpox, the lesions in different stages of development. You see there pointed out a papule. This is a very early lesion, then a blister, and then an ulcer which is crusting over. So that you get successive waves of viremia with successive crops of skin lesions, and this is very characteristic of chickenpox. Okay, the virus establishes latency in sensory ganglia of the nervous system. These can be either cranial nerve ganglia or spinal nerve ganglia, and it can reactivate, causing zoster, or can reactivate asymptomatically. This is zoster, the characteristic one-sided band of blisters. This is what we don't want. This is zoster in the ophthalmic division of the nerve causing, trigeminal nerve causing eye involvement. And this can be very destructive. Okay, complications are uncommon, but they can be serious. This is usually a relatively harmless disease, but it isn't always. Chickenpox can lead to pneumonia and can have serious pneumonias. There are a number of neurologic complications, and we'll talk about some of them later. There are eye complications. There's a congenital varicella syndrome, and infection, varicella in the newborn, can be a real problem. Okay, the pneumonia, complication of acute chickenpox. Adults are more likely than children to get it. We used to think this was really age-related, but it may be related to smoking more than to age. This was a study in England of 29 adults with chickenpox. 19 of them were smokers, 10 were not. Of the 19 smokers, 7 got pneumonia. Of the 10 non-smokers, nobody got pneumonia. And there have been other reports that have shown the same thing, that smoking is a major factor for developing pneumonia when you have acute chickenpox. Several neurologic syndrome. There's post-zoster neuralgia. There's some confusing nomenclature here. People talk about post-herpetic neuralgia. I think that's a very unfortunate to call it that. This is the Varicella-Zoster virus, not the herpes virus. And I hope that that term will get purged from our language eventually. I won't use it. Post-zoster neuralgia, after zoster, you just keep having pain in the area where the lesions were. Can cause a meningoencephalitis, spreading into the brain. It can cause a paresis of the extremity that was in the area where the zoster was. This resolves about half the time, but about the other half the time, the person's left with some weakness. Can cause what's called a vasculopathy, can infect the cerebral blood vessels, and this can lead to strokes. There's a significant increase in the risk of stroke during the months after a case of zoster in the ophthalmic division of the trigeminal nerve in particular. And there's question about whether the Varicella-Zoster virus is involved with giant cell arteritis, also known as temporal arteritis, is one case of giant cell arteritis. There have been some reports of finding evidence of the Varicella-Zoster virus in temporal artery biopsies. In the eye, it can cause two things. It can cause zoster ophthalmicus. That's where zoster affects the eye. And if you get blisters on your cornea, that can be bad. That can lead to scarring. Also can get acute retinal necrosis. This is someone who's been infected with this virus. It can reactivate and attack the retina without having any rash at all. This is seen more in immunocompromised patients than in patients with completely healthy immune systems, but it can happen to anybody. It can lead to blindness in one eye or in both eyes. Anytime you suspect you might have any of these eye complications, start the patient on Acyclovir and get the ophthalmologist. You want to confirm the diagnosis, plus get the ophthalmologist's advice on management of the problem. The congenital syndrome is more likely if the mother has active chickenpox in the first or second trimester of the pregnancy. This is relatively rare. Most women who have chickenpox during pregnancy, the baby's fine, but in some cases he's not. This can cause limb hypoplasia, skin scarring, neurologic damage, which sometimes it goes away, sometimes it's permanent, and also eye damage, which can be permanent. Okay, and the perinatal syndrome, this happens if the mother has active chickenpox during the period from 5 days before delivery to 2 days after delivery. Dr. Bocchini was helpful in helping me understand this. The fear is that the baby got showered with the mom's viremia at a time when the mom didn't have any antibodies and the baby hadn't been born yet and he didn't have any antibodies either, so that he's at risk for serious disseminated varicella after he's born. Now, after he's been out for 2 days, if the mother's first evidence of chickenpox is after he's been out for 2 days, then he's just a healthy child, exposed by the respiratory route, and is just at the same risk of other healthy children who get exposed with the respiratory route. Okay, so what to do about this? There's several things, 3 vaccines, an immunoglobulin preparation, and some antiviral drugs that we have to work with. So we'll talk about each one of them and then talk about their uses. Varivax is made by Merck. It's a live virus vaccine. This is by an attenuated strain of the Varicella-Zoster virus. This was developed by Michiaki Takahashi and his group in Japan in 1974 by serial passage in cell cultures, some of which were human cells, some of which were other cells. And the vaccine currently is supposed to contain at least 1,350 plaque-forming units per vaccine dose. This is a vaccine for chickenpox. Zostavax, also made by Merck, also a live virus vaccine. It's the same strain as in Varivax, but at a much higher dose. 19,400 is supposed to be the minimum plaque-forming units per dose. This is about 14 times the Varivax potency, and this is a vaccine for zoster. Shingrix is another vaccine for zoster. This is by GlaxoSmithKline. It's a subunit vaccine, contains 50 micrograms of Varicella-Zoster Virus glycoprotein E. Glycoprotein E is essential for virus reproduction, and it's also the primary target for the immune response. Also contains 50 micrograms of an adjuvant called AS01B. This is a vaccine for zoster. The adjuvant is meant to increase the immune response to the glycoprotein E. Varizig is made by Congenital company in Canada. It's a globulin preparation from humans with high titers of antibody to this virus. It's meant for immune-compromised persons exposed to chickenpox, for infants whose mother had chickenpox during that crucial period, from 5 days before to 2 days after delivery. Want to give it as soon as possible, but it may be useful up to 10 days. Okay, medication to actually treat this virus is the Acyclovir group. Acyclovir and the other drugs in this group inhibit the viral DNA polymerase. Acyclovir is available intravenously, also orally, but it's poorly absorbed orally. Famciclovir and valacyclovir are better absorbed orally. The MIC for the Varicella-Zoster virus, that's the minimum inhibitory concentration you need of these drugs, is higher for the Varicella-Zoster virus than it is for the herpes viruses. So you'll notice that you need higher doses to treat this virus than you do to treat the herpes viruses. Resistance is quite rare. If you actually think you've got a resistant Varicella-Zoster virus, send it off for PCR to confirm that it is indeed resistant, and then look up what the currently available drugs for resistant Varicella-Zoster virus at the time you find one. I've never found one. I doubt any of you all will. Okay, effectiveness in preventing chickenpox. This was a study in children age 1 to 14 years with 9 months of follow-up. And this study showed 100% efficacy. There were 468 in the Varivax group, 446 in the placebo group. Nobody got chickenpox in the Varivax group, and 39 got chickenpox in the placebo group. Problem is, it was only follow-up for 9 months. And when you followed it up later, there was some waning of the immunity. This was a case-controlled study of 1 or 2 doses. That first study was just a single dose, and that was what everyone was giving when the vaccine first came out. And this looked at, this was a case-controlled study, looked at vaccine history of cases and controls. Okay? And they looked at, they had 71 cases and 140 controls, and they looked at the vaccine history. And of the children who'd gotten no vaccine, there were 5 cases and only 1 in the controls. The patients who'd gotten 1 dose of the vaccine, 66 cases, and the ones who'd gotten 2 doses of the vaccine, there were no cases, and 22 in the control group. So 1 dose had an efficacy of 86%, 2 doses 98.3%. Okay, deaths from chickenpox, they used to happen. They were rare, but they did happen. They still happen, but they're a lot rarer. Back in the 1990 to 94 period, before the vaccine was in wide use, death rate from chickenpox was 0.41 deaths per million population. 2005 to 2007, after the vaccine was in wide use, just 0.05 deaths per million, about an 88% reduction. Okay, how about zoster after Varivax? These was a study looking at children age 18 with zoster from the records of the Kaiser Permanente group in Washington and Oregon, 2005 to 2009. Okay, and they found 83 zoster cases that had been vaccinated, 171 that had been not vaccinated. Of those 83 that occurred in the vaccinated group, 43 of them occurred with a wild-type virus, 38 with the vaccine virus, and 2 with a possible recombinant virus. It looked as though it was a recombinant between the vaccine virus and the wild-type virus. Among those who were not vaccinated, all 171 were wild-type. There was no vaccine virus in the unvaccinated. The incidence of zoster was 48 per 100,000 patient years in the vaccinated group and 230 cases per 100,000 patient years in the unvaccinated group, for a reduction of 79%. So, no, Varivax won't protect you lifelong from getting zoster, but it certainly decreases your risk of it. Decreases your risk of both chickenpox and zoster. Okay, how about Varivax in HIV-infected children? This was a study in children with HIV, on therapy for HIV, who had been given the Varivax vaccine. In this particular study, it wasn't a terribly big study, but the effectiveness against chickenpox was 82% in spite of HIV, and the effectiveness against zoster was 100%. It's also been used in children with leukemia with some success. It, just as in children without leukemia, it doesn't completely eliminate the risk of either chickenpox or zoster, but it decreases the risk of both of them. And in children with leukemia, I didn't find any reports of serious complications. The oncologists in this country are generally not vaccinating with live virus vaccines right now, but in small studies it has been safe and effective. Okay, on to Zostavax. This is the zoster vaccine, same live virus strain as in Varivax. This was a placebo-controlled trial, 38,546 subjects, mean follow-up 3.13 years. These were, that should be 60, not 6. These were immunocompetent patients at least 60 years old. It reduced the zoster incidence by 51.3% over 3 years and reduced post-zoster neuralgia by 66.5% over that 3-year period. Adverse effects were similar in the Zostavax group and in the placebo group. Okay, this is a longer follow-up of part of that same group of patients. They said that for funding reasons they couldn't follow the whole group out further, but they followed some of them. In the Zostavax group, continued follow-up for about 7,000, and also in the placebo group about 7,000. And this was additional follow-up years 4 through 7 after vaccination. Efficacy against the zoster declined down to about 40%, and post-zoster neuralgia efficacy just declined a little down to about 60%. There has been a reported case of Zostavax dissemination. This was a 79-year-old man with chronic lymphocytic leukemia. His most recent immunosuppressive treatment had been 6 months before he was given the Zostavax vaccine. He received Zostavax. About 3 weeks later, he developed a widespread vesicular rash, got lung and kidney involvement, multi-organ failure, and died in spite of intravenous Acyclovir. The third vaccine we'll talk about is Shingrix, which is the component vaccine. There's no live virus in Shingrix. This was a clinical trial, placebo-controlled, men and women age over 50, 2 doses 2 months apart. Now, Varivax is 2 doses, 3 months apart. Zostavax is just 1 dose. Shingrix is 2 doses, 2 months apart. And this was a mean follow-up for 3.2 years. Okay, had about 7,000 in both groups. Vaccine efficacy against zoster was 97%. There were some more adverse effects from Shingrix than from Zostavax. Local reactions in 81.5% and systemic reactions in 66.1%, contrasting with only 11.9% local reactions in the placebo group and about 30% systemic reactions in the placebo group. Most of the local reactions were pain at the injection site, and the systemic reactions were mostly myalgias, and the difference is probably from the adjuvant. Other adverse effects were similar for Shingrix and placebo. Okay, there was a sub-study of Shingrix in subjects over 70, again, placebo-controlled, 2 doses 2 months apart. Mean follow-up here was 3.7 years. About 6,500 in both groups, vaccine efficacy 89.8%. So get more efficacy, no chance of a live virus getting loose and attacking the patient, but more injection site pain. Okay, adverse effects this time. Local reactions, 74% of the Shingrix group, about 10% of the placebo group. Systemic reactions, 53% in the Shingrix group, 25% in the placebo group. Local reactions were mostly pain. Systemic reactions were mostly fatigue. The difference probably from the adjuvant. Other adverse effects were similar for Shingrix and placebo. Okay, now, we've been talking about prevention. We'll talk a little about treatment. This was a study of Acyclovir for chickenpox in healthy children ages 2 to 12, about 350 in both the Acyclovir and the placebo group. Number of lesions was less in the Acyclovir group. The lesions healed sooner and the patient defervesced sooner, but there wasn't a big difference. How about Acyclovir for zoster? These are immunocompromised patients with hematologic cancers. There are 11 in each group. This was Acyclovir versus Vidarabine, which is an older antiviral, which was in use before Acyclovir. On the Acyclovir group, none of them went on to a disseminated rash. It all stayed as the local band rash. In the Vidarabine group, 5 went on to a disseminated rash. Pain started decreasing after 4 days in the acyclovir group, after 7 days in the vidarabine group. Crusting of the lesions was complete by 7 days in the acyclovir group, 17 days in the vidarabine group. And healing of the lesions was complete at 17 days in the acyclovir group and 28 days in the vidarabine group. So with Zoster in this immunocompromised group, acyclovir made a big difference. Okay, Richard Whitley recommended a 21-day regimen of acyclovir and prednisone. And this was a four-way study: acyclovir plus prednisone, acyclovir plus placebo, placebo plus prednisone, or placebo plus placebo. And the prednisone dose was tapered over 21 days. The acyclovir dose stayed at the full 800 milligrams 5 times a day for the whole 21 days. Okay, the acyclovir plus, that's my mistake, acyclovir plus prednisone had the fastest healing and least acute pain, but the differences were not large, and there was no difference in long-term pain. Okay, this was another study. There were 4 groups. There was acyclovir plus prednisone for 7 days, acyclovir plus placebo for 7 days, acyclovir plus prednisone for 21 days, or acyclovir plus placebo for 21 days. Okay, both the longer duration and the steroid group had faster healing and less acute pain, but there was no difference in long-term pain. There were more adverse effects in the steroid group, particularly dyspepsia, hot flushes, and edema. And the authors concluded that the longer duration and the steroid were not worth the benefits. And they recommended the 7-day course of acyclovir with no steroid. Having done it both ways, the 21-day regimen with the steroid is a major bother. It's a lot more expensive to go 21 days of 2 drugs and 7 days with 1 drug. And you've got to instruct the patient on how to taper the steroid dose and write that out for them and calculate everything. When you add in the possibility of side effects and no benefit for long-term pain, I personally think that the 7-day course of acyclovir or famciclovir or valacyclovir is the way to go. Okay, some recommendations. For healthy children, first dose at 12 months of age, and second dose anywhere from 15 months to 3 years. To 6 years of age. How about a non-immune exposed person? If the patient's at least 12 months old, not pregnant, and not immunocompromised, give the Varivax vaccine as soon as you can, probably useful up to 5 days. And give the second dose 3 months after the first dose. Okay, how about non-immune immunocompromised? You want to weigh the advantages and disadvantages of Varivax, check for specific recommendations, and either give Varivax, you give it as soon as possible, but it's probably useful up to 5 days, or if you don't want to give Varivax, give the Varizig as soon as possible. It's probably useful up to 10 days. Okay, how about an exposed pregnant patient? If the mother's immune already, you don't need to do anything. If the mother's non-immune, give Varizig, the immune globulin. We don't want to give vaccine to pregnant women because of the theoretical risk of getting the congenital varicella syndrome from the vaccine. It has been given accidentally to some pregnant women, and there have been no complications reported, but it's probably not a good idea at this time. Okay, how How about Varivax and HIV infection? Can do it if the helper T lymphocyte count is over 15% in children or over 200 in adults. Okay. How about indications for Acyclovir? For either chickenpox or zoster in an immunocompromised patient, probably not for chickenpox in a mild chickenpox in a completely completely healthy child, probably minimal benefit of that. Give it for either chickenpox or zoster in pregnancy. Acyclovir is safe in pregnancy, and so are Valacyclovir and famciclovir. Give it for chickenpox in an infant. Give it for zoster in anyone. Give it for severe disease in anyone. And with the infant, you would want to give it intravenously. For severe disease, you'd want to at least start inpatient intravenously. And you might finish the last few days orally if the patient responds very well. IV acyclovir in severe disease. Oral famciclovir or valacyclovir in mild disease. Okay. Okay, so our puzzling case, did zoster have anything to do with this patient's neurologic decline? We'll never know, but it's better to prevent chickenpox and zoster than to worry about them. All right, questions? Well, thank you. Anything?
What is the preferred vaccine for adults?
Shingrix at this time, because of the it's not a live virus, so you don't have the theoretical risk of dissemination of the virus, and also because of the higher effectiveness. The downside, of course, is the injection site pain and soreness, but everybody came back and got their second dose in the clinical trial, so it apparently wasn't severe enough that they didn't want to get the second dose of the vaccine.
Does it need to be repeated if the patient subject got infected?
If a patient got zoster after Shingrix, that hasn't been studied. But I haven't seen any recommendations for repeating the vaccine.
Person will get it.
Yes.
It's not 100%.
No, it's not 100%. You're absolutely right. It's not 100%. None of these vaccines is 100%. Okay. Anything else?
How can we get the hyperimmunoglobulin?
Okay. There's a company in California that it's made in Canada. There's a company in California that markets it. I'd recommend, if you need it, call the pharmacy and find out how to get hold of it. Anything else? Okay, well, thank you.